the GP cone, and I'm going to just very, very sort of gently push it to lengthen. You'll notice here that as I sort of push down the GP cone, it's kind of getting snagged a little bit, maybe because the GP cone's a little bit bent. And sometimes when you get a GP cone and it's looking like it's getting a bit sort of stuck, what you don't want to do is push it down because you'll concertina the end. Just give the little GP cone just a little bit of a twist, bit of a turn, and that'll just sort of gently push in nicely. Hello, welcome to this week's clinical case. And this is a case of an upper left 7 that I've completed a root canal on. And the particular challenge found with this tooth was that of difficult access. And I suppose if you've done enough root canals, or you're newly qualified, and you might find that you've got a patient who doesn't open very wide, this can provide a significant challenge to be doing a root canal on, especially in fact when you've got a very, very back tooth, because I suppose when you look at the kind of the angle of the jaw and where the pivot of the jaw rests near the TMJ or at the TMJ, a posterior tooth, the patient has to open extra wide. And again, more significantly with root canal, you are placing instruments in the mouth which are quite long. So this was a challenge, but you can see at the end that we've got a really, really nice obturation. We did a really, really nice result, and subsequently we also found an MB2 in this tooth, and the MB2 had its own separate canal and portal of exit. So we'll get on with the case. First of all, of course, we're going to place rubber dam. It's really, really important. And because of the limited mouth opening in this case, the coronoid process, when the patient was opening, was getting in the way. And I like to use a rubber dam clamp with wings, because what I do is I place the rubber dam onto the clamp itself, and I place the clamp and the dam onto the tooth. I feel that that's the best way, and especially with limited access, because if you're just putting a clamp on and then you're stretching the dam over, sometimes that can be almost impossible. Also, what I like to do is once I've placed the rubber dam on and I've sort of flicked the rubber dam off the wings of the rubber dam clamp, I place my rubber dam forceps back onto the clamp, and I open it slightly so the rubber dam slips kind of underneath the clamp. But in this case, this sort of wiggle technique wasn't working very well, and I had to use this sort of liquid dam here. And this is not a conventional liquid dam. It's kind of like a light cured sort of plasticized liquid dam, and I like this because this liquid dam's got a controlled set. So once it's set, it doesn't sort of go everywhere. Once the rubber dam's on, we're ready to remove the temporary filling. I'm using a pear-shaped fast handpiece here. I do like to use these smaller length burrs in difficult access, because for obvious reasons. What I do is I use the sort of small burr in the first instance. I give it a good clean out with the ultrasonic, and then I get a larger burr because that reaches down the cavity space nicely. And what I'm doing is just removing all the old temporary filling material, and I'm going to go straight in with my initial irrigation. And I kind of like doing this because it gets rid of all that kind of necrotic pulp tissue, and we can see now with the cavity space that it's nice and open, and we can see quite a few canal spaces here. So this is a really nice sign. And straight away I'm going to go for the palatal, and I'm going to use a size 25 high flex variable taper, and I am just using this as kind of an orifice opener, although with the palatal it's not really significantly needing any much more kind of coronal flaring. And the great thing about these high flex files is they can be bent into shape, and this is important in this case because obviously the patient's got limited opening, so I can kind of bend the file into place and then sort of hook it into the canal space and then activate the motor. And with the palatal, I feel like it's quite open, and I feel like I can go straight for my working length check straight with my Apex Locator. In this case, I'm using a size 10 K file, and trying to get this in with the limited opening is quite difficult, but I just use a pair of locking tweezers here to push the K file in. And when we hook the K file up to the Apex Locator, There's a little bit of jigging, there's a little bit of watch winding just to get through the apex. You know, I like to push the K-file through the apex and then push the K-file backwards until we reach 0, and that's my 0 reading. And once we have found 0 on our Apex Locator, it's found to be 19.5 millimeters. So first of all, we've got our working length with our palatal, and then I'm ready to do some shaping. I do like to use a glide path file. In this case, I'm using a size 10 high flex glide path file. The problem with these glide path files is they don't bend and keep their shape like the further diameter files up. So in cases of limited access, it's difficult for me to get my rotary file in these cases, and it can be a bit frustrating. But it does bend a tiny little bit. In these cases, what I do is usually ask the patient just to open really nice and wide, and we get it in nicely here. And once we've shaped with the glide path file, I'm going to recapitulate, because I feel like maybe there's a sharp bend in the apical third in this palatal canal, and that was kind of demonstrated when I was trying to gain my working length. And recapitulation is all about keeping the canal patent. So if there's any debris down there or on the necrotic tissue, and that's sort of churned up with your rotary files, this hand file here is just to keep it open and patent. And then the glide path file reaches to the working length really easy. So I'm ready to shape the palatal with my master apical file 0.5 millimeters away from the 0 reading. And these are the great things about these glide path files. What happens is they shape things really nice and easy. Once the palatal's done, I'm going to work out the working length of the DB. Again, I know that the DB is quite wide and open. So when I place my size 10K file down and I hook it up, I just can't quite get past the 0 reading on this canal, and I think maybe it's slightly blocked in a way. So in this case, I've gone straight for the working length and it hasn't worked out. So what I'm going to do is I'm just going to pull the file out. I'm going to unhook the Apex Locator, and then I know at what point I have reached with my hand file with the Apex Locator, and I know how far I've got, and I know the furthest point I've reached with this file. So and I know how far I've reached with this file because I've adjusted the rubber stopper. So what I'm going to do now is I'm going to try and watch wind and negotiate past this rubber stopper. So with the Apex Locator hooked up, it's difficult for you to try and negotiate, but also it's difficult to know if you're through the apex or not. So this is why this rubber stopper is really important. I'm just going to have a little fiddle here, a little bit of watch winding, and you notice now that my rubber stopper is now pushing past the furthest point reached previously. So what I'm going to do now is I'm going to hook up my Apex Locator, and it shows that I am through the apex. And I suppose in a way, when we hooked up the Apex Locator last time, I was very close, and it was probably just a very complicated apical anatomy. And again, same as before, I'm going to push the hand file through and then going to back it up, and then once it reaches 0, that is my 0 reading that I'm going to be happy with. And the 0 reading in this case is 21 millimeters. And it's the same protocol as before. I'm going to use my size 10 glide path file at 21 millimeters at the 0 reading. That's going to be nicely shaped. I'm just going to be really mindful of the apical anatomy here because it was difficult to get my hand file down. And then again, the glide path file actually reaches quite nicely, and I'm happy to go straight with my master apical file 0.5 millimeters away from 0. And again, it's really difficult to reach my hand file in because of the limited opening, but it's really important that I recapitulate, get rid of all of that nasty debris, make sure that the canal is painted, ready for obturation. And then for arguably the most difficult file to negotiate with limited opening, that's the mesiobuccal canal. And in this case, what I've done is I've made quite an obtuse bend with my hand file, which I don't really like to do, but in this case, I've got no choice to get the hand file in, and also I'm utilizing my mirror and some locking tweezers just to get in there, because if I use my fingers in this case, it's probably going to get in the way, and I'm not going to be able to get the kind of vision I want to try and negotiate or just even get inside this canal. And it's at this point I hook up the Apex Locator and the readings are absolutely wild, and this drives me wild. And what I didn't realize at the time is the Apex Locator was running out of battery. So I suppose in a way, if you are having trouble with your Apex Locator and you get wild readings, it could be for a really number of reasons. It could be if you've got a lateral canal, or depending on what Apex Locator you've got, possibly it's too dry or too wet, or God forbid you've perforated. But I think in the very first instance, if you're getting wild readings, I just want you to check the battery. It's probably the battery. And I know it's such a simple thing, but when you got your mind focused on something really complicated, the fact that you haven't filled it up with enough juice is something that you sometimes forget. Well, I know I do. But in the end, we get our mesobuccal working length. It's found to be 21.5 millimeters. And again, very simply, it's just the same shaping protocol. I'm using a size 10 high flex glide path file. I feel like this is pushing to length really nicely. So I'm going to go straight for my master apical file, the size 25 variable. I could go from a 10 to a 20 to 25, but in this case, I know high flex really well. So I know in my hands, I can go straight up to the working length. So I'm happy with that. And when we assess the access cavity floor, we can see straight away that we can see an MB2 orifice. And the very first thing that I think about when I see an MB2 orifice is, has it got its own canal and portal of exit, an own apex, or does it join with MB1? And in the first instance, what I'm going to do is I'm just going to negotiate with the size 10K file. And sometimes when it does join, this size 10K file doesn't reach far down the canal, and you think to yourself, maybe it's joining with the MB1. But in this case, I feel like the K file was actually reaching quite nicely down to a relatively nice length. So what I'm going to do is I'm going to open up the coronal third of this canal. I didn't do it with the other canals because they weren't as closed or closed up, and I'm just using a size 10 glide path, and also I'm actually using my master apical file, and this is for cost effectiveness. So I could get an orifice opener, but this size 25 variable just works just as well as an orifice opener. And again, I'm just opening up the coronal, possibly the mid third of this MB2 canal, and we're going to hook and then I'm going to swap my size 10K file for a size 8D finder. These 8D finders are perfect. They're like a kind of a smooth board shape file. And these usually slip really nicely to length, especially having issues with sclerosed canals. And then what I'm doing, I'm just using gentle watch winding, in and out. And the Apex Locator has completely run out of battery at this point. Again, this is another thing about when you are taking your all of your effort and your concentration on doing a difficult root canal. I knew that it was out of battery, and I sort of plugged it into the wall and thought, right, well, I'll do the shaping of the other teeth, and hopefully there'll be enough battery. And then I forgot to press the switch for the plug. In some countries, there's no switch, but in the UK, when you plug something in, you need to use a switch as well to turn it on. So there's a little bit of insight into UK dentistry there, and me being a bit silly, not plugging my Apex Locator in to charge it up. The great thing about my Wirelex Apex Locator is the actual unit, that the Bluetooth unit that sits on the patient's rubber dam, that in itself is its own Apex Locator. So it's got a kind of like it's not as posh as obviously using the LED screen, but it works. So in this case, you can't see the LED screen because it's not on, but I'm actually using the Bluetooth unit as an Apex Locator. And I've actually found the working length of this MB2, and it's found to be around 21 millimeters. So what I don't want to do is I don't want to take this as the working length just yet, because obviously a size 8 is not very accurate. And sometimes when you shape the tooth, what happens is it straightens out the canal, which then in turn makes the working length shorter. So I'm doing some sort of step back shaping. So the working length was found to be 21. So I got my size 10 glide path file and shaped up to 20. And then I'm going to get my master apical file and shape that up to 19. And then what I'm going to do is I'm going to get a larger diameter file. In this case, I'm using a size 10K file. Again, arguably, maybe I should be using a 15, but in this case, I'm using a 10. What I do is I reach this to length, I hook it up to the Apex Locator. And interestingly, the working length in this case is found to be 20.5 millimeters. So the act of me shaping the canal space has straightened out the canal, and it's made the initial working length found with the 8 longer than now with the 10. So that's really interesting, and that's another vote for not going to find out the working length too quickly. Sometimes it's better to kind of shape the coronal to mid third before you go straight for that working length. And obviously, if you get the wrong working length and you shape it either too long or too short, that's going to affect the outcome of the tooth. And then once we've found the working length, same shaping protocol, I'm going to use the glide path file, and I'm going to use a size 25 variable high flex just to shape that MB2. And there we have it. We have 4 shaped canals. We're ready for our cone fit radiograph. Again, what I like to do is like to measure the cones. I like to fit them to length. I then like to push them to length, feel for tug back, and then and I like to snip off the edges, because when I place my rubber dam on, sometimes the excess GP can be pulled out by the rubber dam. And we look at the cone fit radiograph, and it's looking fantastic. It's not as clear as I'd like it, but we've got difficulty in access in this case, so taking a radiograph was really, really difficult. We can actually see the superimposition of the upper 8, and in fact this isn't in the correct sort of perpendicular plane we'd like to take a PA, but I'm happy with this. Gives me enough information. And in fact, when we take our post-op radiograph, you can see that the superimposition of this 8 isn't as pronounced, and this is because the endodontic holder we use this is because of the endodontic radiographic holder we use is quite bulky, and this is to allow for the rubber dam clamp, and also if you're using files to sort of be in position when you take an x-ray. And what another little trick that I like to do is I take the cone fit radiograph with the endodontic x-ray holder, but at the end with the post-op, I usually like to use a normal holder, because that is less invasive in the mouth, and the patient can bite down more successfully and get a more perpendicular x-ray beam. So once we've confirmed the cone fit radiograph is everything fine, all the GP points are to length, we're going to remove the cones, we're going to put them in my GP disinfector, and we're going to do our final irrigation protocol with me, sodium hypochlorite activated, then we're going to use EDTA activated, and then we're going to use sodium hypochlorite again activated, and we do this until all of the solutions run nice and clean. So we know that the inside of the tooth, all that debris, all that muck, all that nastiness is being washed away. We're then ready to dry the canal space. Again, I use this GP disinfector ring, and I like to use it as like a focal point for me and the nurse. She puts the paper points in this kind of dry area, and I know that she knows where to put them, and that's why I know where I'm going to pick these up. I just use these interlocking tweezers just to pick up these paper points, and I am drying the canal spaces. That's really, really important, because we're using a bioceramic sealer, and if it's too wet, and the bioceramic sealer will just wash away, and that's no good to anybody. And then I'm going to use a size 10K file. I'm going to place that into sodium hypochlorite. That's to be disinfected to be used later. And then I'm going to just hook up my visco tip here to my bioceramic sealer, and I'm going to load it all up. And essentially what I'm doing is getting everything ready for me just to go boop, 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 and get everything sort of done very, very quickly. I'm going to pick up the GP cone I'm ready to obturate with. I'm going to dip this in some isopropyl alcohol just to get rid of the sodium hypochlorite residue. And then I'm going to air dry the GP cone there, and that's ready to be placed into the mouth. I'm going to lock it in with my locking tweezers. I'm going to place them to one side, so that's ready to go. I'm going to pick up my bioceramic sealer, and then I'm going to go straight for the palatal in this case. And what I like to do is I like to use these visco tips in the coronal to mid-third, and I'm going to put quite a significant amount of bioceramic sealer just in the palatal because it's quite wide. I don't want to have any voids. I'm then going to use a disinfected hand file just to introduce the bioceramic sealer to length. I'm going to adjust the rubber stopper on this hand file about 2 to 3 millimeters away from the working length of that particular canal, so I'm not going to push it all the way to the end. And then once we've introduced the bioceramic sealer to the canal space, we're going to pick up the GP cone, and I'm going to just very, very sort of gently push it to lengthen. You'll notice here that as I sort of push down the GP cone, it's kind of getting snagged a little bit, maybe because the GP cone's a little bit bent. And sometimes when you get a GP cone and it's looking like it's getting a bit sort of stuck, what you don't want to do is push it down because you'll concertina the end. Just give the little GP cone just a little bit of a twist, bit of a turn, and that'll just sort of gently push in nicely. And then we're going to use a heated plugger. I'm using a BL unit here at 230 degrees, and I'm just going to cut the excess off. Of course, I'm not going to use heat far down into the canal space because this is not great for bioceramic sealer. So you're going to cut the excess off, get some Mach 2 pluggers, and just condense down that GP cone. And what that does is it just pushes the bioceramic sealer into all the like nice nooks and crannies, and make sure that the sort of oval shape of this palatal canal is adequately filled with bioceramic sealer. Once the palatal's done, I'm ready to obturate the distal buccal root, and it's the same obturation protocol as before. And then when we look at the post-op radiograph, you know, it looks beautiful, doesn't it? You know, these are the types of cases where you look at them and you think, this looks beautiful, really, really, really nice. I suppose if you're being super, super critical, if you look at the distal buccal root here, there's a small void between the obturation and the core filling, but I'm relatively happy with that. And we can see the MB2 here is nicely shaped and it looks fantastic. And overall, thanks for watching. Listen, if you have any comments, if you have any criticisms, if you looked at this video today and you think you could have done better, you could have done something different, don't hesitate at all to comment in the section below. Let's get a debate running. I love any kind of criticism or discussion. It's how we learn, it's how I learn. I've learned so much from all of our viewers here. And if you want to support the channel, please like and subscribe this video. And if you want to take that support further, we've got a membership program. The membership program is a small monthly fee. It supports the channel. It keeps me independent. But also you have early access to content. Usually I run about 2 or 3 weeks ahead. So if you just can't get enough, please join the membership program. And I will see you next week for next Friday's clinical case. Bye-bye.